Welcome to today's Explainer, everyone. Whether you're a physician, a nurse, a physiotherapist, or a clinical officer, look, if you work in healthcare, you're going to see patients with joint pain. It's just a fact. And honestly, differentiating inflammatory arthritis from degenerative joint disease, that's got to be one of the absolutely most important clinical skills in musculoskeletal medicine. Making the right call early on has massive, literally life-changing implications for your patient's prognosis, their treatment pathway, and their overall quality of life. All right, here's our quick roadmap for today's Grand Round style explainer. We're going to start with two patients, two diseases, then move through pathophysiology, epidemiology, clinical presentation, and our diagnostic approach. Finally, we'll wrap the whole thing up with evidence-based management for both osteoarthritis and rheumatoid arthritis. Let's get to it. Section 1. Two patients, two diseases. So picture this. A patient walks into your exam room and they're complaining of joint pain. Right away, your brain has to navigate this central diagnostic challenge. Is what I'm looking at an inflammatory process, or is it a degenerative one? Let's put two clinical vignettes side by side to really see this in action. Take patient A. She's a 65-year-old female complaining of pain in her hands and knees. When you examine her, you feel these hard, bony nodes at her distal interphalangeal, or DIP joints. And her pain, it's highly mechanical. It gets worse with effort and really aches at the end of the day. Now, look at patient B. She's a 45-year-old female, and she comes in with this soft, kind of boggy, symmetrical swelling right in her metacarpophalangeal, or MCP joints. Her pain follows more of a stress pain pattern, meaning it's the absolute worst at the end range of motion. So we've got two patients. They both have hand pain, but we are looking at two entirely different diseases here. Moving on to Section 2, pathophysiology and epidemiology. To understand why these patients present so differently, we've got to look at the demographics and mechanisms. The epidemiological burden here is huge. Age and female sex are major risk factors for both conditions. But the sheer scale of osteoarthritis, it's staggering. Women actually account for 60% of all osteoarthritis cases globally, and they carry roughly a 47% lifetime risk for developing knee OA alone. Rheumatoid arthritis is also more common in women, but pay attention to the timing here. RA typically strikes way earlier, usually between ages 30 and 50, whereas the incidence of OA spikes sharply after age 50. Now, the stark contrast between these two diseases really jumps out at the cellular level. Rheumatoid arthritis is a systemic, autoimmune, cytokine-mediated attack. You've got T cells, B cells, and macrophages infiltrating the synovial fluid, and they drive this aggressive pannus formation that literally eats away at the cartilage and bone. It's vicious. Osteoarthritis, on the flip side, isn't just simple wear and tear like people used to say. It's actually a super complex biomechanical failed repair process. Chronic stress leads to cartilage fibrillation, and the chondrocytes start inappropriately pumping out matrix metalloproteases like MMP13, which basically degrades the joint from the inside out. You can actually see how this failed repair process unfolds right here. The initial loss of hydrophilic proteoglycans causes the cartilage to lose its bounce, its elasticity. And as that cartilage degrades, the joint space starts narrowing, but unevenly. This puts a ton of increased mechanical load on the underlying bone, which leads to subchondral sclerosis, that's the hardening of the bone you see, and the formation of osteophytes, or bone spurs, right at the margins. It's basically the body desperately trying to stabilize a failing joint. Section 3. Clinical presentation and differentiation. Okay, let's talk physical exams. How do we tell patient A apart from patient B in real time? Well, the absolutely crucial dividing line is 30 minutes. Write this down because it's a massive clinical pearl. Whenever a patient reports morning stiffness, you have to ask exactly how long it lasts. If the stiffness resolves in under 30 minutes, that points strongly to osteoarthritis. But if that morning stiffness is dragging on for over an hour, no way. That is a major red flag for active inflammatory rheumatoid arthritis. This gelling phenomenon after prolonged inactivity is a classic hallmark of systemic inflammation. Joint distribution is your next major clue, and it's kind of like a map for your diagnosis. Osteoarthritis loves weight-bearing joints. Think hips and knees. And in the hands, it specifically targets the distal DIP joints and the carpometacarpal joint of the thumb. Plus, it's frequently asymmetrical. Rheumatoid arthritis, though, classically presents as a symmetrical polyarthritis, both sides. It heavily targets the small joints of the hands, specifically those proximal pips, the MCPs, and the wrists, and it almost entirely spares the DIPs. That's a huge distinction. Visually, the difference is just striking. Check out the complete cartilage loss and those large osteophytes at the DIP joints here. Clinically, these are what form Heberden's nodes. If you palpate them, they feel hard, bony, and fixed. Contrast that with our RA patient, patient B. If you felt her joints, they would feel soft, warm, tender, and kind of boggy. That's because of the active synovial hypertrophy and effusion going on in there. Section 4. Diagnostic approach and testing. So what happens when the clinical picture is a bit murky? That's when your diagnostic branching point heavily relies on specific lab markers. In OA, your acute phase reactants, like ESR and CRP, they should be totally normal, though keep in mind severe obesity might cause a very mild elevation. RA, however, typically presents with elevated ESR and CRP. When it comes to autoantibodies, anti-CCP is highly specific for RA. But I want to highlight a really surprising pitfall here. While high rheumatoid factor titers strongly suggest RA, mild RF positivity can actually happen just from normal, healthy aging. So remember the golden rule. Always treat the patient sitting in front of you, not just the lab value on the screen. And when plain radiographs just aren't cutting it, advanced imaging is a total game changer. Ultrasound can brilliantly confirm osteoarthritis by revealing those osteophytes right at the joint margin, while completely lacking the intense synovial hypertrophy and increased Doppler signal, which represents hypervascularity, that you'd absolutely expect to see buzzing around inside an actively inflamed rheumatoid joint. Before we go ahead and lock in a diagnosis, though, we've got to keep our differential broad. For instance, an acutely hot, swollen, single joint, that could be gout or pseudogout, but you absolutely must rule out septic arthritis first. Also, remember that psoriatic arthritis can cause DIP involvement too, so always check the patient's skin and nails. You don't want cognitive bias blinding you to other sneaky culprits like viral arthritis, spondyloarthritis, or broader connective tissue diseases. Moving to Section 5, Evidence-Based Osteoarthritis Management. Once we're super confident in our diagnosis, our management pathways just diverge completely. Let's start with the targeted, evidence-based plan for patient A's osteoarthritis. The absolute mainstay of OA treatment? It's actually not found in a pill bottle. According to guidelines, non-pharmacological interventions are paramount. We're talking about sustained weight loss of greater than 7.5 to 10% of body weight for overweight patients. You combine that with physiotherapy, assistive devices, and highly tailored aerobic and strengthening exercises. Losing that weight has a massive dose-response relationship with pain reduction, and it genuinely delays structural progression of the disease. Of course, when lifestyle modifications aren't enough, we escalate pharmacologically. For superficial joints, like the knee, topical NSAIDs are preferred initially. Why? To minimize systemic toxicity. If that fails, or if we're dealing with deeper joints like the hip, then we move up to oral NSAIDs, but you always have to keep those cardiovascular and GI warnings top of mind. Intra-articular glucocorticoid injections can provide some solid, short-term, localized relief. Oh, and note this. Oral opioids are explicitly not recommended, period. Ultimately, if the joint fails completely, joint replacement surgery is our definitive end-stage option. All right, Section 6, Evidence-Based Rheumatoid Management. Now, let's pivot to the entirely different, highly aggressive treatment strategy required for patient B's rheumatoid arthritis. While OA management is largely about symptom control, RA management is a literal race against time to prevent irreversible joint destruction. Early rheumatology referral is absolutely critical here. We use what's called a treat-to-target strategy. The goal is rapid clinical remission using conventional DMARDs like methotrexate, and we often escalate to advanced biologics or JAK inhibitors if that target isn't met fast enough. And because these patients are systemically inflamed and immunosuppressed, keeping up with their vaccination status and managing their cardiovascular risk are vital parts of the whole shebang. And unlike OA, where labs are pretty much just for the initial diagnosis, managing RA requires constant objective monitoring. You must be tracking those acute phase reactants, ESR and CRP, at every single clinical evaluation. These markers are basically telling us if that systemic fire is still burning beneath the surface, and they guide us to adjust our DMARDs therapies way before permanent radiographic damage even occurs. So let's bring this all back to our initial clinical vignettes. The next time you see a patient with joint pain, I want you to challenge your own biases. Are you casually dismissing a young woman's early RA as just a sprain and completely missing the crucial window to save her joints? Or, on the flip side, are you inappropriately treating an older patient's mechanical OA with systemic steroids? Making this distinction quite literally dictates the destiny of that patient's joint. Your clinical acumen, your ability to take a detailed history of that morning stiffness, to meticulously palpate and feel the difference between boggy synovitis and bony osteophytes, and to deploy the exact right evidence-based pathway, it profoundly impacts your patient's trajectory. Keep this framework in mind to tackle the arthritis diagnostic challenge head-on. But it leaves us with a pretty compelling question for the future. As we keep developing more advanced biomarkers and targeted immunotherapies, will we eventually be able to intercept and prevent these diseases before the very first joint ever aches? Thanks so much for joining me on today's Explainer, and I'll catch you next time.